You didn't all come together. No, we didn't come together. Yeah. Paris. So because like 27 hours. Oh my God, we're in the state with that. It's a lot of travel, but then we get to get to our hotel. I initially went to the other hotel to the bottom, 10 minutes away. So I went to that first, exactly, and then I called Sharyn. But it's not like that's not good enough. And then, but I just found out. You're not all the same. We are, but I went to the wrong one initially, and then I think the wrong one, right? He did, that's what it was.
Some coffee or tea?
Yeah, the wrong
air conditioning. Oh, we can make it. No, don't make it. No, it is cold. We can make it like a little bit less. هذه بيقولوا yourself. Thank you.
And during that time, we also provide education with our patients in that capacity. And then I'll touch a little bit on exercise testing. We do more of the exercise testing with the physical therapy department, but we do some of the follow-ups. In later stage lung disease, we don't do a lot of them, but it is something that we do in our time. All right, some basic spirometry here measures the amount, volume, and the speed or flow of the air that can be inhaled and exhaled. It's a very primary diagnostic test that we do for all our patients. We focus on technique, especially in pediatrics. That is the challenge. There's a lot of directions given for this test, and we focus on technique. Without good technique, your results aren't reliable or reproducible. So we spend a lot of time introducing, sometimes around age 5, definitely by age 6, working on their technique. So basic technique that is sitting up straight, feet on the ground. Sometimes if they're standing, we want them standing straight up, shoulders back. Footstool can be helpful because little ones often can't touch the bottom of the boot or in the chair, so we want them to be not fidgeting when they're doing this. Making a good seal around the mouthpiece so that all the air goes in and out to be measured. Getting them to practice on breathing in and out through the mouthpiece. It's an awkward feeling for them because of the shape of what we're asking them to do. So get them to practice that and take a big breath in and blast it out hard and fast and then blow till they have no more air and then a big breath in at the end. Sounds really simple, but putting that all together in a young child is a challenge. So here's just a little diagram that kind of shows the assessment of how their effort was. So it's hard to tell by just watching them what their effort is, but our flow volume loop gives us lots of information so we can correct and redirect on subsequent efforts. And we try to focus on one thing. So the factor we're really looking for is that FEV1, that value there. So getting that hard, fast blast out is one of the biggest things we focus on at an early age. So like I said, definitely start by age 6, but in our center we will look at patients 5, maybe even 4-year-olds if the providers say, hey, this one might be able to do it. The goal really is to get them comfortable with doing it. It's something they're going to have to do at every visit or on a home device as they get older. And so getting them comfortable with it, taking away any anxiety they may have about a task, and getting them to perform is really our goal. Then we review our results. Our equipment gives us trends, so we want to know if they're at baseline, if they've improved, especially with Tricaptan out. We've seen huge changes from people's baseline over the years. So now we have new baselines we're establishing here, or whether they've declined, which is also an important thing to share with the care team. We have a protocol at our center where if they have declined more than or 10% from their best value in the last year, then we institute a bronchodilator protocol where we give them a bronchodilator and then we repeat spirometry. This helps the providers understand, is it a reactive airways component? Could it be an infection component? It gives them one more piece of information in the whole visit to see where their treatment should be. This kind of just highlights pre and a post bronchodilator. So we hope if we're going to give a bronchodilator, we're going to see a change. And even if they never changed with a bronchodilator, we still give it because every test is its own little snapshot in time of what's going on. So tips for success. This is really the challenge with pediatrics. We involve our families in a lot of what we do. Parents know their children the best, so we ask for input. You know, what have they done before that's made it easier? Is there a certain technique? We use animation in our spirometry, especially for the young ones. So has that worked before? Is there anything that will kind of take away any of the stress of performing the test? We ask the parents to participate in. We also share amongst team members things that have done and worked well. If we know that somebody has anxiety, for example, if somebody has anxiety and they are going to get a throat culture, you know, which one should we do first? In our center, 99% of the time they're getting a pulmonary function test done before they see anyone else, but sometimes they might need something else done just because the longer they're in clinic waiting, the more anxious they are about something. So we work with all our disciplines to try to provide a very safe and stress-free visit for our patients. We identify who may have troubles and what we should focus on. Age isn't the only limiting factor. This is a big component to their health, and often it comes with the anxiety of, if my numbers are decreased, will I have to stay in the hospital or be admitted to the hospital? So a lot of them come very anxious to get this done, and so part of our job is to kind of settle that out, distract them from that, get them to perform the best that they can. But some kids just, they have a higher level of that, and so understanding that, working with our social work or other people to help how we can make that a better experience for them, we work together as a team. And then we always take advantage of any teachable moment. So while we're working with our patients, and the ones that are good at it, they pop them out 1, 2, 3, and that all is good, but you know, you can tell after their first effort if maybe something's going on. You already have looked at their numbers from before, you know where they're at, whether they're at baseline or below, which is really what we want to focus on. Then we start asking the questions. Are you doing your daily treatments? Are you doing your airway clearance? And maybe we get them to hop off. If we have to give them a bronchodilator, we're reviewing technique. So all in that 15, 20 minutes we might be with the patient. We're trying to cover all those bases and reinforce and re-educate. Special considerations. Really, it's not about age, it's about what they can do. Like I got some 4-year-olds that can put a 16-year-old to shame. There's just beautiful technique, and it's effortless to them. And then, so we really focus on each patient as an individual, and what will work for them. So again, we want to make it calm. I think Many of us prefer to not have the parents in the room, which is a challenge when they're young because they're already nervous to come to the visit and they don't want to be without mom and dad. But as they get more comfortable, they're willing to come and they see a familiar face. And then we get them more relaxed and we can joke around with them and we can put them at ease and we get better numbers. And it's less stressful for the parents. They're really focused on that number. So then instead of having the therapist in there being the coach, you now have 2 or 3 coaches. Mom, dad, the therapist trying to get the best effort. And it can get a little overwhelming in the room. You just have to get creative, find something that works for them. Again, any incentive is great. So most programs have some animation that works great for young patients. I have actually used it on teenagers as well because it gets them to focus on glowing longer, not so much the hard blast, but the longer glow. And so I don't limit that just to the younger children. And when they're first starting out, it's not necessarily about getting reproducible data, it's getting the good technique. And that's what we stress with the parents, to try to put them at ease, that they'll get it, that they'll eventually get it, and they'll do it. And this is a building step process. So we review oftentimes when we have them for their spirometries. We review their organ therapies, making sure they're doing their medications in the proper order. We review technique and go over cup popping, especially if they're popping a lot during those first attempts. Or we can also use that to gather food samples, so we always have cups available for our patients. The other thing we do sometimes in coordination with pulmonary function testing is we'll do simple exercise test or the 6-minute walk test. It's not something we use a lot in our center as a regular diagnostic, but we do, it's there, it's available. Usually if there's more progression in lung disease, it's something that is used to track. So it measures the distance a person can walk on a flat surface in a 6-minute period. We have a measured section in a hallway that's 100 feet, so we know from this point to that point, back and forth, we can easily track the distance. It's a flat surface, it's not carpet, it's unobstructed, so it's an easy way for us to track. And it's also not a high traffic area, so we set them up. Sometimes we'll do a spirometry or even a complete pulmonary function test ahead of the walk test. If that's ordered, then we let them test. It's important that they're completely at baseline without exertion before we start the test. So we let them sit. Sometimes if they need more than 10 minutes, we do that. And this really kind of reflects this walk test, what their level of tolerance is in daily activities. So contraindications really are more for adults than children. We don't usually see children with angina or having myocardial infarctions. Resting heart rate needs to be less than 120 beats per minute. Blood pressure needs to be less than 180 over 100, and they have to be able to actually walk. So we get a baseline PFT, we let them rest, we get a heart rate, oxygen saturation, and then we use a work scale for dyspnea. So at rest, we get all that. And then we ask them to walk as quickly and consistently as possible. We have a portable pulse oximeter attached so we can measure their oxygen saturation. And we just ask them to go back and forth. So if somebody's holding the spirometer device, the oximeter device, and we're walking with the patient. So you're kind of trying to walk a little bit behind them because you don't want to set the pace. We want them to set the pace. And we let them go, and we're measuring 6 minutes. So then we report those at the end of the test, how was the total distance walked. Again, we ask them to share where their level of dyspnea is, and then fatigue, and we get their heart rate. That's the board scale that we use, and we have that printed out, and we ask them, where are you at? And we get them to share that with us to see if there's a change. If you're performing it and they complain, we ask why they feel they might need to stop. Definitely chest pain, shortness of breath that makes them not be able to continue, leg cramps, anything that makes them look like they're completely overexerted. We have them stop and we have them rest to get their vital signs. Sometimes they may need oxygen during the test, so we have portable oxygen that we can give them, and we start with 1 liter oxygen. If they drop their oxygen level below 88, we automatically stop the test, administer oxygen, let them recover, and then we try to go back to the test. If we need to do it with the test, then we continue to do it either mostly with adults, but sometimes in later stage lung disease, they're already on oxygen to do this test. So it's a question of do they need more on exertion? And that's one of the things that we're looking at. So then we take all that information, we share it with our pulmonologist, list of the things that they're looking at, the distance walked, which is really what they want to know, how much can you do in 6 minutes and stay at a comfortable level. They compare to either previous results or some expected normal values of age, height, and gender. We watch their oxygen saturation for any changes and make notation of that, and then their level of dyspnea or fatigue, and that's what we sent. So those are the things with PFTs that we do in basically to support our CF patients. We are fortunate that we have testing capabilities right in the clinic area, so we can have very close communication with our pulmonologists while the patients are in clinic. We need to monitor, try something else. All the talking. So that's just the basics. We do once a year try to get a complete pulmonary function test on our patients that are over the age of 8. It's not a foundation requirement in the care plan, but it's something we like to do with our patients there. Any questions?
Thank you.